TopMedTalk.
Hello and welcome back to TopMedTalk. We are here at Anesthesiology 2024. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree, Chappell, your host. I'm joined by my co-host, Professor Mike Grocott. Hello, Mike.
Desiree, enjoying the day.
Yeah.
We're down to our last interview of the day.
We have Professor Lois Connolly, Dr. Lois Connolly. Lois, thank you so much for coming back.
Thank you. Thanks.
Yeah, absolutely. And then Dr. Professor Jonathan Gall.
Well done.
Yeah,
It's great to be back here again. Thank you.
Yeah, thank you so much. Lois, why don't you tell us a little bit about yourself?
Yeah, I'm a professor at the Medical College of Wisconsin. That's in Milwaukee, Wisconsin. I also serve as the ASA Vice President for Professional Affairs. In this position, I oversee all professional practices and professional standards and regulation. And a lot of what we're dealing with is the economics of anesthesia practices.
I'm a professor of anesthesiology at the Icahn School of Medicine at Mount Sinai in New York City. I've been there for over a dozen years now. For the ASA, I'm our director from New York to the ASA board and the chair of the ASA Committee on Economics, where we handle a lot of all these different payment options, Medicare, Medicaid, commercial insurers, all the coding and CPT coding that's underlying all of it. That all kind of falls underneath our purview.
So Jonathan and I work closely together within the Professional Affairs Division on these issues.
Last year when we were able to sit down, we talked a lot about payment models, different types of value-based care, things like that. For our listeners, talk to us a little bit about the structure of how anesthesiologists are paid in the United States.
We have government payers as well as commercial payers and self-pay. Last year, we really dug into our government payers, mostly Medicare, because of how we're paid in the Medicare government system is fairly poor. And we also got into a little bit about the value-based program in looking at submitting value measures to CMS and getting extra pay for those. Today, I think we want to talk to you more about our commercial payers.
Yeah, the underlying way that we get paid here is all underneath coding, the whole infrastructure for it. We have CPT codes. Surgeon does their surgical CPT code. We have the anesthesia for that CPT code. And we crosswalked it over. We published those books as part of the ASA resources. You probably buy a couple of the relative value guides and crosswork books here in the exhibit hall while you're here. And so those different CPT codes have, for the anesthesia side, they have base units attached to it that reflect the pre-op, intra-op, and post-operative complexity of the care, plus time units that go along with that too. And so the combination of the base plus time units is we wind up setting a claim for that. And then the different conversion factors are the dollar amounts that we multiply those units by. For Medicare, the conversion factor recently has been going down year after year, and it's proposed by CMS, the Center for Medicare and Medicaid Services. So you would take your units for the case, say that's 15 units, and multiply by the $20, that would be your fee afterwards. Medicaid is a state-run program. By each one of the 50 states has a different, you've seen one Medicaid program.
Right.
And they all have fluctuating conversion factors as well. Mine in New York is only $10. It's literally half of what Medicare's is, but in some other states it's as high as $35, $36 or so too. And then the commercial payers is the big fish in the sea here, as far as a lot of their conversion factors wind up being 3 to 4 times as much as the governmental payer ones. And so your payer mix at any sort of practice, having enough commercial payers to counteract the low conversion factors you get from the mandated government set conversion factors can help create a viability for your practice. Then you need to have those extra dollars coming in from those high dollar claims in order to be able to balance your budget for your practice.
Yeah, and so these are all professional fees that are completely separate from the surgery that is paid and how it's paid to the hospital or to the surgeon. It is a bit complicated, Mike.
I'm not from around here. I work in the UK. I'm used to the NHS system. And I'm just intrigued how those two sets of payments balance up, because clearly you've got the government funding, which is essentially a loss leader. You've got the commercial funding, which counteracts that. But how do you exert control over the balance between those two sets of payments?
Yeah, but that's exactly the problem, because our commercial payers want to push us down to Medicare government payer rates. An average case probably builds 12 anesthesia units. Just let's do the math. 12 units times a conversion factor of $20 per unit. Yeah, that doesn't get you too much, does it? So the commercial payers often are individual contracts that negotiate with their employer benefit plans or their commercial payers. So they set proprietary levels of conversion factors based on the types of practice that they are. For example, I work in a level 1 trauma center, do liver transplant, heart transplants. We take care of sick babies. We have an air ambulance for them, really high acuity care, and we're a referral center. We'll go in and negotiate a private contract. You do your negotiation, say $300 per unit to offset your government payers. We're a graying population, which means, I guess they call it the gray tsunami, which means more people are on Medicare than ever before. So the number of patients that are receiving care are higher. So our Medicare payer mix is getting higher and higher. So what happens is our commercial payers need to be able to balance that payment out a little bit for us so that we can maintain our practices and how we practice. So you go to each individual contract.
The negotiations you want to have with these commercial payers is more of that fair market value. You get to show the value that you bring, the training that your group has, the types of complex cases that you wind up having, previous contracts you've had in the past, and how the benchmark of federal payers, whether it be Medicare or Medicaid, it's our fair market value, not the government mandated rates that you wind up having in that negotiation. So it's crucial to have strong negotiating power when it comes to those discussions to try and get the conversion factors there that can help you actually have a more viable practice.
Jonathan, one of the questions that I have is this individual clinicians, anesthesiologists that are going and negotiating, or is it en masse? Is it per group? How does that work?
It depends on your group practice, right? So there are types of individuals out there that kind of just go to office-based settings or might follow around a surgical group and work with them in different settings like that. And so they would have their individual negotiations with payers. It's tougher to have a strong negotiation with them when you're just one body, right? Small groups and academic practices would have practice leaders go and do it on your behalf. Myself, we're both in academic practices. It's more leaders inside of our health systems administration that does those negotiations. And sometimes it's on the professional side by itself. Sometimes it's just on behalf of your own department and practice that you're doing it. Other times it's rolled into the entire negotiation with the payers. Some of the big name payers we have here in the United States are Blue Cross Blue Shield, United, Cigna, Aetna, the 4 big ones, the BUCA plans as the acronym goes. And so those negotiations would happen more from like your practice leaders, your health system administration there. And then there's large group practices here in the US too that are multi-state. And oftentimes they have an entire arm for managed care negotiations that will help each one of the individual practices to negotiate those fees at each one of those sites.
There have been lots of changes this year. Walk us through some of the biggest changes that have really impacted anesthesiologists.
Yeah, I think we can start off with the beginning of the year, 2024, a revenue cycle billing company that United owns underwent a cyber attack on their system. That attack affected almost every bill, be it pharmacy, hospital bill, physician billing in the whole U.S. And it shut down all revenue coming forward in that cycle. And that played out for quite a few months.
February 21st of 2024, they got the cyber attack. And essentially, they're a main clearinghouse for all types of bills, as Dr. Connolly was just describing. They're like a bank clearinghouse, but for healthcare things. Anesthesia practices across the country, hospitals, pharmacies, whatever, they couldn't send bills to payers, and they couldn't collect for the bills that they already sent. So it was just a shutdown period. And now all these practices are having to still make payroll 2 weeks from now, but they can't get any collections come in to help pay for that payroll. And United, who was their sister Optum owns Change Healthcare, which is the main revenue cycle company that Dr. Connolly was just referring to. They kind of took advantage of this situation, right? So there were a couple practices that couldn't make payroll. They're now in dire straits. And Optum's going in and trying to buy the practice. How awful is that, right?
It was pretty predatory. Independent groups that used Change for their revenue cycle management company really suffered tremendously under the cyber attack. This went on for months and months. To top it all off, United offered to loan them money at an interest rate to be able to meet their payroll. A lot of anesthesiologists went. Any payment to themselves was just to be able to meet their obligations, took out short-term loans or whatever. We did survey our ASA members, and it was quite significant.
So they represent about half the transactions nationwide. And so fair to say at least half the anesthesia practice nationwide in one way, shape, or form were impacted by this, because You might have a different billing service than Change Healthcare, your main anesthesia billing company, but yet many payers have contracted with Change to be their main clearinghouse. Take Blue Cross Blue Shield from whatever Midwest state. They only receive claims through the Change Healthcare clearinghouse. So you might be using one of the other billing services here, but they have to send their claims through Change in order to get to that Blue Cross Blue Shield in Midwest state somewhere. It shut down essentially half of the different transactions throughout the country for a while.
In your all's role and from an ASA perspective, what has the advocacy been like for supporting anesthesiologists across the country?
We wrote letters.
Yes.
We filed complaints. We got articles published and everything. We raised awareness of this sort of stuff. When bad acting was happening on behalf of United and stuff, we were able to go to the press with that sort of stuff as well. We did surveys. We tried to help support their practices. We wanted to be supportive and provide resources and that sort of thing.
They just posted that the Change cyber attack cost $2.7 billion for them to settle that cyber attack. I'm not very familiar with this, and the black web is through cryptocurrencies, so it's interesting how they settle these cyber attacks. But $2.7 billion it cost United Healthcare. So is that a lot of money for United Healthcare? Optum themselves posted a $63.7 billion profit last quarter. At the end of
all of this is that,
yeah, they're still making a lot of money.
yeah.
So obviously money in their pockets is not money in yours.
So do you feel like anesthesiologists that were impacted by this are coming out and finding respite and able to support their practices now as things back on track?
They're slowly coming back on. I believe it was around late August, early September when they got their clearinghouse back up and running again. They basically had to rebuild the entire software structure at Change because they didn't know where inside of all the SQL coding and stuff like that in their software were all the different bugs lying and stuff. So they rebuilt the entire thing and took about 4+ months. And so some practices, my own practice included, had started sending claims late August, early September. And so now it's in bulk and you're hoping that you're within the timely filing, within each of your contracts, with the different BUCA plans and et cetera, because most of them have timely filings of after the patient service, it needs to be within like 60 days or 90 days. It took them over 4 months to get this. So we're up greater than 120 days that you're trying to file these claims. That was one of the other things that ASA had some of their advocacy towards, was getting suspension of those timely filings by a lot of these different payers as well during this period of time.
Yeah. Even before all of this, ASA had filed an antitrust complaint against United Healthcare in 2021. So we've had our eye on the predatory nature and the anti-competitiveness of United Healthcare for a while. And just this year, I think the DOJ has investigated United Healthcare and has put them on notice. I don't know what the outcome of that is at this point in time, but
they've done some formal reports. We were working on this for a number of years, this back when Jeff Miller was still there. We put a lot of efforts, put letters into the Department of Justice. They've done their investigation, took a solid 3 years or so, and now they've come out with some formal reports about the anti-competitive and antitrust behavior between Optum and United, and they're going further with that now as well with more investigations.
Yeah.
But that doesn't stop United Healthcare's issues this year. And one that came to light is the New York Times expose on their shared savings scheme, which was released in April.
Another one of the subsidiaries, they own this company called Multiplan. Multiplan has this business plan essentially where
they're middlemen. They negotiate out-of-network costs.
It could be a surgeon, could be a hospital, it could be an ambulatory surgery center. They're out of network with a certain plan, say Aetna or Cigna or whatever. They submit the claim to them, and then Multiplan comes in, and they're contracted to do this on behalf of Aetna, and comes up with an allowable charge that they should have for out-of-network bills for that.
But they're owned by United, just so you know.
Yeah.
That is the tangled web.
It's amazing how they get a margin on every little thing within the healthcare industry. It's impressive. Suppose you submitted a bill for $1,000. Multiplan comes in and says, actually, we've got some data here. It's dirty data, but it's data that we use to say this bill should really only be $300. You should only allow $300. And that difference, that $700, Multiplan's going to take a chunk of that as their fee. And then the plan that paid them to do that takes the other chunk of it, still represents that on the patient's fees as $1,000. They only pay them $300, keep their own profit, and send some to Multiplan as well. It's a very conniving scheme out there, which is why the New York Times did Congress's newsletters before it did ours.
United Healthcare is huge, and their web is like tentacles. They own a lot of healthcare, and they make profit on almost all of that. But United is definitely one of our biggest issues, I think, in commercial payers. But that doesn't end at all. Can you imagine if you're submitting a bill under the No Surprises Act, independent dispute resolution? Okay, so there's some laws or rules around whenever you need to submit a claim for underpayment through the IDR, independent dispute resolution process as well. If United Change has shut down your billing and your revenue, your stream, and you can't submit that claim through the IDR process in a very timely fashion, you could lose out on the ability to negotiate through the IDR process as well.
So that there's some smaller practices out there, say there are like less than 25 physician anesthesiologists out there who are out of network with a plane or two, but they're relying on the regular amount of revenue coming from those out-of-network cases. And if you have to go through the IDR process as part of the No Surprises Act, there's still some regularity to it now, 2 years in. But with the Change Healthcare going down, if your biller was using Change at all, they actually can't even go into their data systems to tell you that you had a claim with an out-of-network plan. But this is what the QPA, the qualifying payment amount that you got back, was from, because you couldn't submit the claim. So there was a number of months there where these small practices who were out-of-network with one of the BUCA plans couldn't even know if they needed to submit a claim into the IDR process. So it just further pushes out their collections on those potential claims that they were doing cases on February 22nd, 23rd, and moving forward, but they're not able to actually collect on any of those and can't go through the other paperwork, busy work processes in order to try and get those collections in.
Gosh.
All the while still doing the safe.
How many are still in the cycle itself? We used to get regular reports on the backlog through the IDR process
resolution of,
but I haven't seen the latest report.
They haven't done one for Q1 of 2024 yet, but
they're usually delayed quite a bit.
Yeah. CMS is understaffed too, just like our work.
So we would know. We would be able to tell exactly what the impact of the Change debacle really had.
The most recent reports that have come out from CMS on the IDR process were for the last 2 quarters of 2023. And in those 2 quarters, anesthesia claims were winning around 80+% of the time. The amount that they're winning is about a solid 200% of what the initial qualifying payment amount they got from the payer. So if the payer only offered them $50 a unit, they're now getting a little over $100 a unit back when they go through this process, and they're winning around 85% of the time.
That's great. Take it back just really quickly, No Surprises Act, because I know we've talked a little bit about that on TopMedTalk, but again, for listeners who may not be as familiar with it, walk us through that really quickly, high level.
The No Surprises Act was really meant to hold the patient harmless in a claim whenever your provider is out of network. Mm-hmm. It would prevent somebody from going after the patient for a service that was provided out of their network. And it's done really well on that, actually. It was a big success. But what really is the crux of the problem is the ability for a physician or a provider to actually go through the IDR process with any sort of success. And the big insurance companies were gaining the system, and there's still some really big problems going through the IDR process. We're working on those, and maybe, Jonathan, you can, I don't want to get into the TMA bills too much, but
you don't want to. That's the fun part. The payer taking advantage of the system, and we're suing them, damn it.
Yeah.
All right?
Yeah.
And so it's not, it hasn't been ASA specifically.
Okay.
It's been the Texas Medical Association has filed 4 different lawsuits. They're called TMA, Texas Medical Association 1, 2, 3, 4. ASA has filed amicus briefs in support of each one of them. We've done that along with the American College of Radiologists and the American College of Emergency Physicians. Other ones who are more wrapped up in this entire No Surprises Act issue that's been going on. And fortunate for us, the provider side, the physician side has won all 4 of those, each one of them. And now we've got another one coming out too. The previous ones were about getting either low payments back, those qualifying payment amounts from the insurers when they first come out. Some IDR entities were increasing the primacy of the QPA when it was coming in as far as their evaluation during the arbitration. There was issues about batching of our claims. Since we just use a conversion factor, we want to be able to batch versus. So we won each one of these, and they're going well. And now one of the issues we're coming up with is that practices, even when they win the IDR process, we're winning around 85% or so, the payer's not paying. So it says in statute that after you lose an IDR, you're supposed to pay the delta from your QPA to the winning amount within 30 days. And some payers out there just aren't doing it.
Yes.
And there's no standards in the regulation about what happens if you don't pay. So now we've got a law coming out, HR 9572. It's the No Surprises Enforcement Act.
Yes.
imposes a penalty on late payment of those IDR Delta payments, along with interest on top of it too. So if you don't do it, you get smacked with the penalty plus interest, and you better pay it.
One thing that the insurers were doing was putting ghost rates in the qualified payment amount for you and calculating what they should pay you. They would put ghost rates or zero rates in there, so you would get a very low qualified payment amount. So that's pretty much cleaned up with TMA 1 and 2.
That was 3, yeah. The ghost rates were TMA 3.
Yeah.
Good.
TMA 4 was the batching, the first two about the primacy.
Right.
Primacy. Depending on what country.
Potato.
I just want to say that the regulation on this is really pending, and they're expecting this to be released, and it was supposed to be November, but I think they delayed it to January of 2025 to really push the insurance companies to pay within an expected amount. But where's the teeth? I don't know.
Yeah.
They could hold out. The people who are very successful in the IDR process usually are bigger groups. North Star Team Health actually is one of the bigger ones, and they win over 90% of them, but they have a well-oiled group working through the IDR process. They've been very successful.
I can't imagine what it's like for small group practice.
Yeah, exactly. Those are the people that really are suffering in the IDR process.
The No Surprises Act is no different. It is just a jobs program.
Yeah.
Honestly. With this whole process now, there's all these companies that will do the IDR process for you. A small practice can now hire a vendor who's probably here in this exhibit hall. Go stop by if you're a small practice and find one that's good for you.
Yes.
That can do this process for you, like what Team Health does internally.
Yeah.
The other large group practices, like North
you
Star
need it.
too. So they have the resources, but if you're a small practice and you don't, you got to hire one of these vendors to help do it for you.
So that's all it costs to you. So there's a break-even point there, depending on how many groups. The ones that are billing on a network are usually small groups that go to different, like plastic surgery offices or endoscopy suites, and they're not negotiating these contracts in network sometimes.
And is this driving consolidation?
Oh, probably. Of course it does. Who wants to be an independent person whenever you can have a bigger group providing you the protection, the deeper pockets to be able to fight some of these issues?
If you're an anesthesia practice and you're suffering from all this different external stuff that's happening with the payers, No Surprises, et cetera, if you're not entertaining the idea of going to a larger group, you're probably having to entertain the idea of becoming employed by your facility. So, because those practices who can't make payroll, they basically have to go to the facility and say, you need to help us out with some extra money for payroll this time around because the collections aren't in. We have all these external things, and if I can't make payroll, I can't staff your hours on Monday morning either. So as a result, a lot of the service agreements are increasing as far as that delta goes. And it's getting to the point where many C-suites at the facilities are having to have that difficult conversation. I think we're going to need to bring you in-house and take over the whole billing process and use our rates for the facility stuff and everything and try and figure it out that way, which is, it's not easy. If that was the best plan A, everyone would be doing that. But it's definitely not plan A and closer to plan C.
We can see this with all types of different groups and physician providers consolidating, like you said, radiologists or different types of specialties.
Mm-hmm.
Really interesting. As we wrap up now, tell us a little bit about some of the pressures that we're seeing from some of the other insurance companies and how that's impacting payment and payment models for anesthesia.
The Blues, Blue Cross Blue Shield. Yeah, they opened up the year actually refusing to pay anesthesia services for colonoscopies in the state of Massachusetts. They fought back mightily, and in fact, even the GI surgeons weighed in on this, and this is really a bad idea. So that didn't go too far, but that didn't stop the Blue Cross Blue Shield from doing other things. We're getting notice of lack of payment for physical status, which is one of the modifiers that we use in our billing. There's other modifiers too, which are on the table, which they're not paying. The CMS for a long time never paid for physical status. And so they're like, okay, we're no longer going to pay for physical status modifiers. Now, what does that mean? Physical status modifier 3 gives you 1 extra anesthesia unit. 4, 2, 5, 3. Aetna said exactly the same thing. Obviously, they hired the same consultant. There's a way to save money. We're not going to pay for physical status modifiers. ASA quickly called them up, weighed in. In fact, you've had some direct conversations with them, Jonathan.
Yeah, we've had to have conversations with both sides of it with CMS, and we're going to pursue that from the ASA level to try and get proper payment for the complexity of our care that we're providing the patients. ASA physical status 1 is supposed to be normal, healthy patient, and then you go up to 5, which is on death's doorstep. getting these extra units still winds up being revenue, which CMS is not paid for. We're pushing for that. With the BUCA plan, and specifically Blue Cross and now Aetna as well, they've shielded themselves from potential anti-competitive, antitrust stuff by coming up with the same damn policy weeks apart from each other by saying that they hire consultants.
Yeah.
I'd love to see that invoice. In the conversations with them too, it's not about clinical care, patient safety, whatever. It is strictly a payment thing. They want to pay for as little as possible across the board, and this is just one more area where they're going after it. And we're pushing back. We're writing letters. We're joining with the American Hospital Association about this, because if we have more or less revenue coming in, then those service agreements have to go up even higher, because we're a victim to whatever they bring in the door. So if they bring in a payer mix that can't keep the lights on for our practice, they get to help.
Yeah, I think the American Hospital Association is a very strong ally of ours when we're undergoing payment issues with our commercial payer insurance.
Yeah,
I think
they're understanding right away.
Yeah.
Yes.
And I think any clinician taking care of patients, we're taking care of sicker, older patients. And we feel that, and it is harder work. They're more complex. We have to do more intervention. And not that we're not vigilant on everyone, but I think it takes more time and work.
Oh, absolutely. Just the pre-op assessment and teeing these patients up for a successful outcome takes a lot of time.
So we always like to ask, what are some of the resources that anesthesiologists here in the U.S. can find more information and support?
Well, the Committee on Economics has a payment page. Do you know what it is?
So you can go to the Payment Progress Initiative, which is on the ASA website, asahq.org. In there, you can find timely topics on economic issues and practice management issues. Those kind of run the gamut of all the different things we're talking about, CMS decreasing our payments and other things that are coming out. There's resources on there too that you can buy as well for the ASA Crosswalk, ASA Relative Value Guide. Those help you understand how all the different CPT codes roll up to how everyone gets paid and everything. We frequently have a Monday morning outreach by our ASA president. There's usually things in there that remind our members of other resources that are live throughout the year related to these different payment issues.
And what I really want to say is, if you're dealing with any issues, especially with dominance of a healthcare insurer in your area. For example, I was talking to one of the Iowa State Society, and they said, wow, their major player there is Blue Cross Blue Shield. They have no ability to negotiate because they have the dominant payer there.
The dominant market share, right?
Yes, 85%. So you'll get a contract that's just said, this is what we're going to give you, or you're going to be out of network. And like I said, especially in smaller areas where you might not be able to do an out-of-network IDR process with a commercial payer, you're stuck signing a contract that you can't negotiate on. So we're very interested at the ASA from hearing from groups that are facing these issues, because the more we know about what's going on there in your world, the better we can help address some of these issues with the payers.
We need the data points, right?
Yes.
The data points to make the arguments. Yeah.
So reach out to the committees and Dr. Connolly, you as professional affairs and things like that. I think it's really important to maintain that communication.
Yes, you can reach us. You will find us on the ASA website.
All right, guys, thanks so much for coming back and chatting with us. Really enlightening conversation. I think it's really important for people to understand how all of this works. I think average clinicians who are not leading groups sometimes don't always understand some of these nuances. So that's really a
pleasure. Thanks for inviting us back and talking about our challenge.
Very informative, really good.
Appreciate you both.
Yeah, thanks so much. And thank you for listening to TopMedTalk. You can always find us on your favorite social media platform. We are now on YouTube. If you see us there, give us a little thumbs up. We are on your favorite podcatcher, and we're at TopMedTalk.com, where you can find more conversations just like this. Do check that out. We'll see you soon. Cheers, everybody.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.